You're listening to the Female Fitness Systems Podcast, where we talk about fitness, nutrition, hormones, and self-care. Because let's face it, we can all use a reminder to look after ourselves more. Now here's your host, Melanie Durrett.
Hey everyone, this is episode number 4 of the Female Fitness Systems Podcast. Thanks so much for listening. Today I'm speaking with Gayle Hulme, an incredibly knowledgeable and passionate pelvic health physiotherapist based in Calgary, Alberta. We cover so much in this podcast, including what the risk factors are for pelvic organ prolapse, to Kegel or not to Kegel, how to look after your pelvic floor while training, and how soon you should exercise after having a baby. There was so much I wanted to ask Gayle in this podcast, but we only started to scrape the surface of a hugely important topic for women. So hopefully I can get her on the show again in the near future. If after listening you want to learn more, Gayle has kindly supplied me with links to articles she's written on the topics she discusses. All these links, including links to Gayle's practice and Facebook page, will be found on femalefitnesssystems.com. As you'll hear at the start of this podcast, Gayle and I are childhood friends, but this is the first time we've talked in 20 years. Gayle, thanks for coming on the podcast. So before we get into today's show, I thought I'd let our listeners know how you and I are connected. We actually grew up together in a great little town called Spiritwood, Saskatchewan, which for people who don't know is in Canada. And we both went to the same university, the University of Saskatchewan, but we haven't talked in probably about 20 years. But we recently reconnected on Facebook, and it sounds like you and I took similar paths after university. We both traveled for a few years, and then we started working in women's health, although it took me a bit longer to get into the field because you were already studying physiotherapy in university. So before we get into what you currently do, I'm just curious about those years after you graduated from physiotherapy. So how many years did you travel and where did you go?
Thanks, Melanie. I'm so thrilled to have you ask me to chit chat tonight. So firstly, I wanted to say thank you for this reconnection. And I think Facebook was something new to me in the last year, and it's really been a really wonderful opening up of reconnecting with people I haven't talked to in a long time. So in terms of what I did right after university, I worked for about 4 to 6 months at St. Paul's Hospital in Saskatoon, doing some general in-hospital physio type work, mostly post-surgical, diabetic, that kind of thing. And then I did travel for about a year. And for half that time, I worked in Kilkenny, Ireland. And what I did in Ireland as a physiotherapist was the pediatric side of things, which was heartwarming and amazing and sad, and all those things kind of rolled up into one. It was a brilliant experience for me. And so then I was kind of done my travels and I needed to do something, but I wasn't sure where I should go, so I ended up working in Ontario for a couple of years. I worked in Kingston and Brockville, which are kind of two little towns close to each other. And I did a variety of things. I did long-term care, and I did some outpatient orthopedics, again, all within the realm of physiotherapy. And it wasn't until 2003 that I landed in Calgary, and I worked in a private practice, doing, again, orthopedics, which I can explain further what that is, but that's kind of the more typical physiotherapy injury recovery that a lot of people associate physiotherapy with. And then in 2006, I nudged my coworker and I said, hey, we should do this. We should make our own practice. And so, yeah, I guess I did that the year before, and the year after, in 2006, we opened up our clinic. So that was 10 years ago. So we have grown now, and we've got a steady little practice in the southwest of Calgary.
And what's the practice called?
It's called Lakeview Physiotherapy and Acupuncture. We kind of shortened it after all these years to Lakeview Physio, but we do a lot of different needling techniques. But we are all physiotherapists who are there, again, with using some traditional and more anatomical acupuncture, as well as some some needling techniques called intramuscular stimulation, or otherwise known as IMS, or dry needling, which is just a real complement to the vast array of physiotherapists and their skills that we have at the practice.
Can you tell us more about your current qualifications and practice areas?
Yeah, so the pelvic health has been, in terms of how I came to it, is not necessarily by accident, but something I almost just sort of assimilated into. It sort of seemed like the next thing that sort of would push my limits and really make me start thinking in a more holistic way. And the way that a physiotherapist gets qualified is to do coursework that is postgraduate. Once you're a therapist, you look at different areas to specialize in, and I've done a whole laundry list of courses within this area in the last 10 years.
So today we're going to start by talking about pelvic organ prolapse. Mm-hmm. So can you tell us more about what that is and who has to be concerned about it?
Specifically, if we're considering men and women, this is a female-driven concern. But one of the things that maybe is a good association with pelvic organ prolapse is the fact is that it's like a hernia that's just happening to come out of the vagina. And that's the reason why it's very specifically all about women. But you know that men can have hernias in various locations, and an inguinal hernia, or in the groin, or an umbilical hernia around the belly button would be examples of what that sort of association would be like from a male perspective. But the uniqueness with women is that we have a vagina, and that vagina has walls. So it has a front wall, a back wall, and certainly the top where the cervix is suspended within, where the uterus is up into the pelvic cavity, or the abdominal cavity, sorry. And so what happens, or what a very specific sort of detail of what a pelvic organ prolapse could be, would be where the bladder sits on the top part of the wall, and that wall is starting to sag. Another option would be that back wall where the rectum is starting to sort of push into, or that back wall is sagging again in towards the vagina. Thirdly, what can happen is that the cervix and the uterus itself can start to fall downward through the vaginal vault. And there's two other things that can happen, which is the what's called an enterocele, or the stomach contents the small bowel can start to fall within the pelvic cavity as well from the top part. And if you happen to have your uterus removed by way of a hysterectomy, the vault itself can also collapse. So that all sounds very bad news bear in terms of all these concerns, the fact that we have a vagina. But what I want people to understand is that as a general rule, women are pretty robust. And, this isn't a fault that we have a vagina, and that this is a concern that everyone potentially could have. It's about recognizing some of the risk factors and recognizing some of the maybe the do's and don'ts to help ward against having something like this happen in the future.
And what are the risk factors?
Mm-hmm. So one of the things that we tend to look at would be something in a genetic kind of way. So without even needing to have an exam, you could look or ask your mom or aunts or grandmothers, and if you've heard of them having a prolapse, there's a potential that you too may have that possibility, because that's about what kind of tissue type do you have. And some people have very stiff tissues, and some people have more loose tissues. And a prolapse isn't just about a defect in these walls that we were talking about. It's also about the ligamentous support and the durability of the fascia. So genetics play a certain role. I'm not going to talk about pre and postnatal just yet, because I think that's really obvious for a lot of people, and that's one of the main concerns. And I think one of the things that people need to understand is that it doesn't have to be related to being pregnant or having given birth, vaginal or C-section. Certainly it's one of them, so it's up there on the risk factors. But even things like chronic constipation, so a constant bearing down, repeated bearing down for months or years, that can put a lot of load on the tissues in the pelvis. Something like a persistent, very long-standing cough, someone with asthma or some sort of other sort of lung condition, or like CF would potentially have that possible risk as well, because they're constantly putting pressure and increasing their intra-abdominal pressure. There are, again, kind of relating to the genetics conversation about the tissue type, but certain types of connective tissue disorders, more on the hypermobility side of things, or the hypermobility syndrome. Obesity. So the more weight that we carry, particularly in and around the midsection, that in a lot of ways can mimic what some of the pressures of carrying a baby can repeat itself as well. Or something more in that activity kind of realm, like a repetitive high impact, like gymnastics, trampolining, even maybe running, possibly. These kinds of activities that increase intra-abdominal pressure. These are all the risk factors. And then most certainly, as I've said already here, is, having carried a pregnancy, whether it's been full term or not. And as you get more and more into getting into the 40-week range and the baby is bigger, that certainly would increase that risk factor exponentially. And giving birth, and quite likely having a vaginal birth that would require interventions like vacuum or forceps, or if there was any perineal tearing or muscle tearing, muscle avulsions within the pelvic cavity, those would also increase the risk factors for pelvic organ prolapse.
I have a few questions about that. So the first is, are there certain styles of exercise that put you more at risk, like, say, lifting heavy weights like CrossFit, or just somebody who trains really hard in the gym, as compared to something like, say, high-intensity aerobics or running, which you mentioned?
Yeah, we are evolving in terms of how we look at how to manage pelvic organ prolapse, or how do we not have people have pelvic organ prolapse in the future. But we have to always weigh that against a person's quality of life in terms of, is this an activity that they can't live without? Is this something that just brings them to a place that they love? So, I think the very simple answer is that, yeah, there may be some things that are related to my risk factor list, like the repetitive high impact activities. And would weight training be a part of that? CrossFit, which is certainly a high level of interval training. But my real answer really is that it's not necessarily about the type of exercise, but how can the person manage that increased pressure, that increased strain that ends up literally going through the abdominal cavity down and towards the pelvic floor. I ask, are there biomechanical disadvantages that they are allowing themselves to be put under? So, alignment of how they are, how they're stacking themselves when they go and do a deadlift, or, if they are doing double unders, which is a huge controversial conversation about, should we be letting women doing double unders, and is this causing pelvic organ prolapse, or urinary incontinence, which is another topic, but again, another problem that women end up facing when it comes to some of these activities. But essentially, it's about balancing the intra-abdominal pressure and optimizing the piston effect of the diaphragm and the pelvic floor. And that almost needs to be discussed a little bit more, if you don't mind. So I talk about this idea. In fact, Julie Wiebe is a physio in the States, and she's really coined the term piston effect, which is looking at what the diaphragm does and the relationship of what the pelvic floor does in response to that. And in a very quiet breathing sort of pattern, when you inhale, the diaphragm moves down, and the pelvic floor muscles and the pelvic floor diaphragm, the urogenital diaphragm, actually would go along with it in a nice restful situation. And that's how things should move. Now, when we see problems arising is when we see a stiffness in that, where the pelvic floor doesn't allow yielding and with the diaphragm, and there's a lot of problems that come around with breathing, as simple as that sounds, but there's a lot of problems centered around that. But if we take then sort of that's rest, and if we take something like even a cough or a sneeze, your diaphragm moves down suddenly and quickly. Now your pelvic floor response needs to be able to react in an equal and responsive way upward to help support the tissues. And so if we put that into a weight training or CrossFit or high impact aerobics, we need to be able to optimize what the diaphragm's doing so that the pelvic floor has a good response to that demand. Does that make some sense?
It does.
So you talk, I'm sure, a lot about breathing to your clients when you're introducing new exercises or heavier weights. And one of the things that I look at, particularly sort of my clientele, is very much a prenatal, postnatal, and they can be varying ranges and ages without having any pregnancies. But a lot of things when we talk about when to introduce exercises and when to reintroduce, strenuous exercises, I think the timing is pretty critical. So, would we say 4 weeks after giving birth? Probably not. And it doesn't matter to me if this was a vaginal birth or if it's a cesarean section. 4 weeks is not enough time, because what we know in tissue healing is that we need a solid 12 weeks to see the changes happen. And it's no small feat to give birth. Again, whether it's a vaginal canal or whether it's a cesarean section, this is a major event on the body. So 4 weeks is just not enough time. Right? And particularly when women add up all the lifting, the bending, and the sitting that goes on with a newborn, the weight of lifting up the stroller or the pram, into the car, these things, combine that with a lack of sleep, there's just no reason to add impact or heavy weights in that period. So for me, walking and some light resistance training that is progressive is a really good protocol. So I kind of alluded to the 12 weeks. That's generally my framework to start looking at who in my client list is able to start to get into some bigger stuff. And again, I said we can do some light resistance training and lots of walking, but again, lots of rest and taking care of yourself in those first few months for sure is important. So I usually give a bit of a line for women to sort of understand that they want me to give them a whole list of exercises that they could do or couldn't do. And I'd rather them follow what their body's telling them. So if they're having leakage, so urinary or bowel incontinence, so it sounds horrible, but it does happen. So losing control of feces or urine during any scenario is not normal. And particularly if that scenario is happening with an exercise or even if it's a certain movement, that needs to be evaluated. If they have pain anywhere, whether it's in the pelvis, whether it's in their tailbone, or maybe it's their knees or their neck, if they're having pain and they're doing something, again, that's a sign that they need to stop and get checked and decide if that exercise is the right timing for them. The other thing, and more relatable to pelvic organ prolapse, is a sensation of heaviness within the vagina. And sometimes that heaviness can feel in the rectum as well. And so if any of those things are happening, so leakage, pain, or heaviness, then I usually adjust the time frame and get them more into a rehabilitative kind of exercise program before getting them doing anything more of a broader scope or more generalized fitness. So the other times that I think that of life that necessitates a progressive look at intense or weightlifting or impact exercises would be looking at after surgery. So any kind of surgery, but particularly pelvic or chest or lung surgeries, or other kinds of stage of life transitions like menopause or before menses start in adolescence. And I think that's a big thing to remember, that young girls their bodies are changing dramatically just as much as women are changing at menopause, or during sort of as they're pregnant and moving along in the pregnancy. Those are really important times to make sure that their body is in a ripe enough condition that they can do the kind of exercises that their body can handle.
Sure. And that was my other question that I had for you on all this, is
Yeah.
that as we get older and our hormones start to change, that can cause changes that could potentially cause prolapse as well. Is that right?
Yeah, what happens is, and in fact, we get a glimpse of it if women are breastfeeding their babes, the glimpse of menopause, and I say that within the vaginal area itself, becomes can get dry. So again, during breastfeeding, it's a temporary sort of transition, but during menopause, it's certainly a more longer lasting effect. And the dryness is a lack of the estrogen that exists within the vaginal canals. And we can't ignore the fact that we actually need testosterone as well. And that's a really, from a hormonal perspective, women can be quite low on their testosterone, and that can cause a variety of things, not just dryness. It can actually lead to pain or even a lack of libido in particular, because testosterone really drives that. So during menopause, how does that impact the pelvic organ prolapse risk? And the impact is then largely about the estrogen loss. And when the estrogen is not there anymore, or in lower quantities, the vaginal walls and the muscles start to atrophy, which is start to not, I think most people know what atrophy is. When after a while, if you stop working out or lifting weights, your muscle mass will start to sort of disappear. If you're thinking about arms or quads or those kinds of things. But vaginally speaking, that we need the estrogen to help sort of keep it plump, to keep good blood flow going. And if we don't, then we start to see some weakness in the walls themselves.
So what's our solution to all of this? Is it Kegels, or I think you might call them pelvic floor muscle exercises now? What would you recommend women do to give themselves the best chances?
Yeah, I tease with my patients that one day I'll write a book, and I'll tell you the title of my book, because that's what I have written already, which is called it's not all about the Kegel. But I have a subtitle to the book, and it says, but sometimes it's okay to Kegel. So it's all about balancing. Does every single woman need to Kegel? No, not necessarily. Not necessarily, because the pelvic floor muscles are very much a postural response. And if everything's working well for them, and they've been checked, and we can confirm that, yeah, there's a good contraction cycle, there's a good relaxation cycle, we can repeat it so many times, there's no signs of prolapse, no symptoms of incontinence, then I would say, no, what we're doing from a physical activity perspective is stimulating those muscles well enough. But yeah, sometimes there's been lots and lots of studies out there to really show how useful a Kegel is. There's definitely studies to show about helping improve what a stage of pelvic organ prolapse. So there's various degrees of how bad a prolapse can be, so to speak. And the Kegel has been shown to be a very useful tool. And same thing with incontinence. But I think one of the questions we had was, how do we strengthen and engage that area when training? And I'm going to go back to the breath, because that is the key thing, because we know that our pelvic floor muscles respond to the diaphragm, back to the piston effect. And what we need to do, which is a very simple thing for women to remember, and men, is to exhale on an exertion type of effort. And that makes sense from a weight training perspective, right? trying to put the heavier part through an exhale. And we can also consider timing a more active Kegel or pelvic floor contraction with a heavy lift, as well as doing the exhaling. So one of the ways, like if you're going to do a squat, what I want to do is inhale as I dip down, and then exhale and maybe even add a contraction as I go up from the squat, because that's a little bit more of the effort. Jumping though, if you want me to speak about that, sometimes again, we want to be able to have the pelvic floor muscles balance with the breath. But when you start doing something more aerobic, it's really hard to exhale. You'd probably would pass out from overbreathing from doing that every time you land on your feet. So one of the things with jumping, like skipping rope, is to do more of a small controlled exhale, kind of like a puffing, gentle puffing without using a lot of abdominal force when doing things like skipping or jumping. But remember, we have to have no urine leakage for that to be a successful tool, or no feeling of heaviness or pain. A couple of other things I think that's super important, which I think you can tell I can talk forever and ever and ever on these things, but a couple of the things, it's not, again, just about the Kegel, it's about the small changes in your postural alignment and control that helps a ton. So one of the things to look at is whether you tuck your tail under when doing a squat or when skipping, for example. One of the things I want women to try is, if you are in kind of that tucked under position, sort of that flattened bum, that is certainly an acquired, usually postpartum figure, where the bum gets tucked under, and the glute bulk sort of loses it, but it also is because we're not activating the glute max because of the natural stance. But if we try to do more of a neutral position, so a little bit not excessively tilted up, but more neutral, you'll find that your pelvic floor actually engages better, and it optimizes your diaphragm as well. So it's again, we don't have to engage in order to make these muscles work the way that they're designed to, which is a very much a responsive system.
Okay, that's lots of really practical things we can start thinking about when we're training. But are you essentially saying that if women are experiencing any symptoms like incontinence, that they probably shouldn't be skipping and
Absolutely.
and jumping? They should be going in to get assessed and start working on it from there?
Absolutely. It's sometimes I think it's because it's been around for such a long time. Women feel like it's their cross to bear that, okay, well, I've had some kids and I leak, and that's just the way it's going to be now. And I just stand on a soapbox and scream out and say that is not at all what we should be settling for. What we want to do is, if there's leakage, it's very analogous to having shoulder pain with an overhead press. Would we continue to overhead press and do more reps and do more weight and continue to have pain without actually seeking treatment, or at the very least stopping that exercise and looking for an alternative that doesn't cause us pain? That's what I liken it to. It is a symptom that your body is not managing something, and in this case it's often intra-abdominal pressure. It's not in the right sort of position or in the right frame, and I say that loosely because we can talk about what that might mean in a second, but we should not have any leakage when we're doing activities.
So, bearing in mind the time, and I have a few more questions I want
Sure.
to ask you, so I'm just going to run through this really quickly. We had a question from a listener who was wondering, she had surgery after childbirth, and she was doing the Kegel exercises, but she said it was tough for her to feel like they're actually having an effect and that she's doing the right thing. I think this is something that would discourage women from actually doing them after a while. So how do women actually know that they're doing them right? Is that something that you can answer on this podcast, or is that just something that they would have to figure out by working with a physiotherapist like yourself?
Yeah, no, I can answer it I can. And if they are having those problems, they should see a pelvic health physio or a women's health physio. I don't know the terminology with New Zealand and Australia. I think they tend to say women's health physio. It's a really, really typical question that I hear from patients. Probably at least 2 or 3 times in my workday, someone will say that. And one of the things is that people know that they should be doing something down there, but they also know it's not going right. And so then they stop. And I would too, if I thought like I'm not doing this right. Often there's a lack of awareness in the muscles. They're small and they're difficult to sense. So from a women's health perspective, what we do is we do internal vaginal and rectal exams that help you sort of get a better sense as to where these muscles are and give you some better cues to see what we can do. There is really no substitute for someone literally cueing you to do this. And plus, we're also evaluating if part of the problem isn't because these muscles are weak. And this is almost a completely different podcast because I could go on and on. But a lot of women are too tight in their pelvic floor. And it's like clenching your jaw. And if you clench your jaw all night long, like some people do, and when you clench your teeth together, and you wake up in the morning and your jaw is terribly sore, terribly tired, and you couldn't bite into, a soft piece of toast, let alone an apple. And that's what happens in a lot of tight pelvic floors. So what I'm thinking that your listeners had is probably a string of tightness in the muscles, and probably one of the things they need to do is actually focus on how to relax them and how to downtrain that gripping sensation that they're not even aware they're doing. And again, a pelvic exam does help that, but there are some ways that you can tell if you're doing this or not. And beyond having a pelvic exam, you can actually, as yourself, as a female, you can use your finger inside the vagina and give it a squeeze. See if you can do a Kegel. Do you feel anything coming around your finger, or if you've used 2 fingers, do you feel any of the tissues coming around, and do you feel your finger lifting up? So there should be a squeeze and a lift. You can also, if you're not super adventurous using your fingers, you can use a mirror, and you should be able to see your pelvic, your perineum kind of puckered together when you're contracting, and then actually letting go and slightly bulging with the release. For more fun, you can use your partner's finger or penis, but I usually say that penises don't tend to be that sensitive, no matter what they tell you. But you can get them to squeeze around the penis and see if they can feel something, right? It'll give you a little bit of a cue. And there are some devices out there. There's some devices. There's one called the Kegel. There's also a new one called the LV. So these are devices that you can, I think the LV you can connect to your phone, but you do have an internal probe of sorts, and it can tell you if you're doing a proper Kegel or not. And there's an app called BWOM, which is not really a sensor of any sort, but does give some really good instructions on how to do a Kegel, and also does touch on what I've talked about with that too tight or the hypertonic pelvic floor.
You're right. This is the subject of many podcasts, Gayle. There's so much we could talk about, and I still have another page of questions. So maybe we're just going to have you on again at some point.
Absolutely. I'd be happy to.
Good. So is there anything else you want us to know about pelvic health before we wrap up?
I think I can summarize it in the fact that we shouldn't leak. Never. Period. We shouldn't have pain, and if we have pain, keep looking for someone who can help you with your pain. Sometimes it takes a couple of practitioners before things get sorted out. And if you're noticing that there's a heavy feeling or literally feeling some tissue falling out of the vagina, that's most definitely a time to be evaluated. There's a ton of things we can do. We can actually do. Again, it's kind of a breathing technique. It's called the hypopressive, and that can actually literally lift the tissues up, and we can revert, say a stage 2 prolapse to less than a stage 1, which is pretty cool, and that's without surgery. And there's devices. There's internal support devices like a pessary, and pessaries are really useful for kind of that CrossFit population where sometimes we're lifting a lot, and that's a even without dysfunction, even without leaking or a feeling of heaviness. But if there's a bunch of weight that's being lifted repeatedly, then there is a field of thought that we might actually use pessaries and internal vaginal support as kind of like the sports bra for the vagina. It's not a sports bra. It's a silicone device that helps create a bit of good tension on the vaginal wall so they don't get forced down with that bearing down or Valsalva. But it's a way to prevent some prolapses that might be happening, and again, more of that really high impact kind of activity. So, that's what I would leave listeners with, is the fact that there are answers out there. There are solutions out there. And if they can't find one, then keep looking, because we are always thinking about new ways to help, particularly women. That's my field of interest, that we can keep active and we can still be very healthy and do the right thing for our bodies at the same time.
So for the lucky people who happen to be in Calgary and could actually work with you, how do they find you?
So our website is just lakeviewphysio.ca. And we do have a Facebook page, which is under that same name as well. And then it's just a phone call. That's really, in terms of scheduling, I have to count them up. I've actually got 7. There's 7 of us who do pelvic health at my clinic, and then another 7 who do general orthopedic physio. So everyone's very much used to seeing women, because we have a reputation that we treat women quite well, and we do see a lot of women with various scenarios. So that is the place to go. I would love to give you some links, though, as well, for your listeners who are, New Zealand, Australia. It's very simple to search for someone who does women's health. It's a simple find a physio Google search, more or less. And I've saved them. So I can send that to you, Melanie, and your listeners can kind of literally click on the links and look into their areas, the country. And I've even put down the Saskatchewan physio one, where, people can look by their location, or if there's a specific therapist they know, they can search for them that way too.
That would be so helpful. And if you want to send me those through, I'll put all the links on my website. So they'll be on femalefitnesssystems.com. And Perfect. I also encourage people, even if they're not going to come and see you, to check out your Facebook page, because you do post a lot of very helpful info there. So like and follow that, and that will definitely help people out as well. So,
absolutely.
So Gayle, thanks again. It's been a real pleasure, and I've certainly learned a lot, and I'm sure the listeners have as well. It's been really cool connecting with you again after all these years.
Yes, same here. Thank you so much. If we need to have some more time, I'm happy to get something specific for you guys to ask me that is maybe burning questions on their minds. I'm happy to do this again.
I would love that. Thanks, Gayle.